Really delighted to give a talk at the NUCD 2021, and I thank Dr. Alok Konungo for inviting me to give this talk. What I'm going to talk today is intermittent fasting. How will it work for diabetics? You might realize that this talk on intermittent fasting is not from a nutritionist point of view, but it is more from the point of view of etiology of diabetes, how you would like to address the etiology of diabetes in terms of inflammation, and how the intermittent fasting is going to help you reduce the inflammation and thereby trying to get the diabetes under control. So when we talk about the burden of diabetes, which is a huge burden, there was a recent paper in one of the Nature journals called Scientific Reports, where they had looked at the diabetes incidence that's growing from 1990 to 2025. In this study, they have really come out with some alarming figures. So what you see in the figure to the right, you will see that there is a global incidence of diabetes, which is going up. Right now, the global incidence is something like 22 million diabetics every year. And the number of people who are developing diabetes is also increasing. And by 2025, they expect 476 million people to have diabetes. So if you look at the total diabetes versus type 1 diabetes and type 2 diabetes, you have a graph with three different colors. What you see in blue color represents total diabetics. And what you see in green color is type 1 diabetes, and what you see in red color is type 2 diabetes. In terms of number of diabetes, all of them are increasing phenomenally. And if you look at the total prevalence of diabetes, that is also going up in a way that is not something that we all will like. It's not just the incidence and prevalence of diabetes that is going up, but if you look at the third one, it is the number of deaths in diabetes that is also increasing. And the increasing is much more with type 2 diabetes than with type 1 diabetes in terms of death. Whereas the number of disability adjusted life years, which is associated with diabetes, is also increasing, which means that as you have diabetes for a long period of time, the amount of disability that you need to face is really getting bigger and bigger. So the problem of diabetes is really big, and the number of diabetics are increasing. It is just like the COVID infection. So the cases are getting more and more and more, and there is no sign of anything happening to plateau or fall. But the important component that I'm going to talk about is the inflammation and type 2 diabetes, how this inflammation is driving and how your fasting, weight reduction, decrease in weight loss, how it would affect the pathophysiology that leads to inflammation and diabetes, so that your diet, especially intermittent diet, that you will, which is becoming a fad, is going to be relevant. And I'm going to talk about, not about calorie restriction or things like that, but I'm going to talk about what kind of diet which is anti-inflammatory that is going to be extremely beneficial, and how the intermittent fasting is going to help in that way, in decreasing inflammation. If you look at the immune system, you will realize that the immune system has got two kinds of immune response. One is the innate immune response, where your body reacts to the offending agent immediately. So in this case, the innate immune response is the first line of defense, and the acquired immune response is the second line or third line of defense. And in this case, immunology plays an important role in diabetes. And the first line of defense, second line of defense becomes extremely important in type 1 diabetes, whereas the inflammation and immunity becomes extremely important in type 2 diabetes. When you look at the markers of inflammation that predict type 2 diabetes, several studies have been done to identify various markers, and one of them is WBC count. Then C-reactive protein is an important biomarker for inflammation, and there are a lot of studies that identify C-reactive protein to inflammation. The other aspect of inflammation measurement is pro-inflammatory cytokine, which is like IL-6 and tumor necrosis factor alpha, also called as TNF-alpha. Measurement of these things, these biomarkers have also been implemented in so many different studies to show the heightened inflammation that are taking place in diabetic patients across the different population. So when you look at the markers of inflammation associated with diabetes, acute phase markers as CRP and IL-6 are elevated in newly diagnosed as well as established type 2 diabetics. In terms of IGT or IFG, which is considered pre-diabetics, IL-6 seems to be much more higher than the tumor necrosis factor alpha. And if you look at the circulating levels of TNF alpha, it is significantly elevated in type 2 diabetes and also contributes to insulin resistance. So these pro-inflammatory markers are very important in terms of keeping the disease and sustaining the disease and even preventing whatever cure that you might give, whether it is from the nutritional point of view or even from drug intervention point of view. So inflammation is something that needs to be brought under control. So when you look at the pathophysiological mechanism, linking body fat and insulin resistance to elevated inflammatory markers, it becomes important to know that all these are connected. All these are connected in a way that the adipose tissue not just serves as a fat storage organ, but it is also important in cytokine production. And there are toll-like receptors and acute phase hyperresponsiveness that are important, including the T cells that drives the inflammation. If you look at the cartoon, you will see that genetic makeup is very important. Genes give susceptibility. And these genes give susceptibility, including for acute phase hyperresponsiveness. So this susceptibility leads to increase in body fat. So this increase in body fat, of course, is also related to our dietary habit, not just with the genetic component, but genetic component plays a very important role. So when your increased body fat is the result of altered lifestyle, there are certain things that happen in your body where oxidized form of LDL becomes the culprit, and the oxidized form of LDL generate antibodies to oxidized form of LDL. And this leads to an important component in inflammation and vascular damage. So there are things like some of the bacterial infections and other things that bind to toll-like receptor 4, acting as an exogenous ligands, also drive acute phase hyperresponsiveness. So when you are in acute phase hyperresponsiveness, you will realize that this leads to vascular damage, endothelial damage in particular, and elevated circulating levels of acute phase reactants that include C-reactive protein and other cytokine that we spoke about that are pro-inflammatory in nature. So you have a strong genetic component, you have a lifestyle component, and you also have interaction with your environment in terms of what kind of bacteria that you interact with. All these things together can lead to vascular damage and diabetes. And also this could be measured in terms of acute phase reactants. So you have an exposure that is the lifetime socioeconomic adversity. And these exposures are all of different types. Then you have a phenotype, which is the altered gene expression and unhealthy lifestyle. All these leads to elevated inflammation. And this elevated inflammation makes you highly susceptible to develop diabetes. And if you already have diabetes, this leads to insulin resistance and difficulty in treating these patients with the existing forms of therapy, whether it is oral drug or insulin. So the outcome in relation to the lifetime socioeconomic adversity will be type 2 diabetes. An important component of this is the elevated inflammation. So when you look at the adipose tissue inflammation in the pathogenesis of diabetes, you will realize that the adipose cytokines. So obesity is associated with inflammation in adipose tissue. And it's important because the infiltration expansion of macrophages, which produce inflammatory cytokines that interfere with insulin signaling and loss of protective cells that promote adipose homeostasis. So there are a lot of things that are happening here in terms of adipose tissue secreting pro-inflammatory cytokines. And here in this particular paper, you have a clear documentation of involvement of macrophages in the inflammation, adipose tissue inflammation, that could lead to the type 2 diabetes in the pathogenesis of type 2 diabetes. When you look at some of the T cell effects, CD8 positive effector T cells contribute to macrophage recruitment and adipose tissue inflammation. So these T cells are very critical. And in this particular study published in Nature Medicine, they found that large number of CD8 positive effector T cells infiltrated obese epididymal adipose tissue in mice fed with high-fat diet whereas the number of CD4 positive helper and regulatory T cells were diminished. So these kind of T cells drive the pro-inflammatory response, and that happens in the adipose tissue where there is a macrophage recruitment taking place. But if there is something that could be done where we can change the composition of T cells from effector CD8 positive T cells to regulatory T cells, then this becomes a favorable situation in terms of decreasing the inflammation. This is something that is pretty much achievable because there are two kinds of adipose tissue in your body. One is the brown fat, another is white fat. Brown fat is not pro-inflammatory. Brown fat has CD8 positive T cells, whereas it's the white fat, which is predominantly abdominal adiposity, that constitutes the pro-inflammatory aspect of the adipose tissue inflammation. When you look at the T lymphocyte infiltration in the visceral adipose tissue, which is the seat of inflammation in diabetes, you might not be overly obese, but you could have abdominal obesity with a normal BMI. In those instances, the abdominal adipocytes become very important, which are white adipocytes, white fat. The T lymphocyte infiltration has been documented in the visceral adipose tissue, and a primary event in adipose tissue inflammation and development of obesity-mediated insulin resistance is driven by the pro-inflammatory T lymphocytes that are present in the visceral adipose tissue. So there is a T cell-driven inflammation that recruits macrophages, and you will also see that the regulatory T cells are protective in nature. Lean adipose tissue, also called as lean fat, is enriched with unique population of regulatory T cells, and this is what we should get and develop. And it's possible that this could be influenced by some of the diet. And the observations in this particular study suggest that harnessing the anti-inflammatory properties of regulatory T cells to inhibit the effect of metabolic syndrome will have a therapeutic potential. So how can we make all these things so that you can create an anti-inflammatory effect to decrease the inflammation in predominantly pro-inflammatory environment? So this is where the brown adipose tissue comes. Brown adipose tissue harbors a distinct population of regulatory T cells, and this particular study done and published in PLOS 1 clearly shows that the regulatory cells are critical determinants in immune response and metabolic control, and they show that systemic ablation of regulatory T cells comprised of adaptation of whole body energy expenditure to cold exposure correlates with impairment of thermogenic markers. So what it means is the BAT or brown adipose tissue harbored a unique subset of T regulatory cells that has a unique signature. And if you were to remove these T regulatory cells, then you would revert the brown adipose tissue to more or less effective to be a white adipose tissue in its functionality. Then you saw about macrophages, you saw about regulatory T cells, CD8 positive pro-inflammatory T cells in the adipose tissue. Now comes the B cells, which are responsible for producing antibodies. And these B cells have also been documented in the adipose tissue, where there is a chronic inflammation that is characterized by T cells, macrophage infiltration of visceral adipose tissue, plus the B cells that are important component being added. So this study summarizes as that the importance of B cells and adaptive immunity in insulin resistance suggests a new diagnostic and therapeutic modalities. There have been studies where B cells, which distinctly create a marker called CD20, and if you have anti-CD20 antibody, you come up with a situation where you block the B cell activity, decrease the inflammation, and get the pro-inflammatory cytokines down. So there have been some studies that have been done using anti-CD20 antibody to be important in the treatment of obesity and pro-inflammation in situation with insulin resistance and of course diabetes. So obesity is clearly documented as a pro-inflammatory state. And if you look at the COVID-19 situation, this was published in Nature Reviews Endocrinology in July 2020, where they clearly show obesity and impaired metabolic health in patients with COVID-19, that obesity is a pro-inflammatory state. And if you develop COVID-19 in an obese individual, it becomes hyperinflammatory. And this hyperinflammatory state leads to death in obese patients. So the preponderance of death in obese individuals developing COVID-19 is much higher than non-obese individual developing COVID-19 infection. So obesity serves as an important comorbidity in terms of mortality in COVID-19 infection. So obesity is not something, and then the background of this is that the obesity leads to pro-inflammatory state, and this pro-inflammatory state makes the obese person much more vulnerable to death compared to non-obese individuals for COVID-19 related mortality. So obesity and mortality, as you can see from this particular paper that was published in British Medical Journal, central fatness and risk for all-cause mortality. So in this particular study, they conclude that the central fatness, including waist circumference, waist-hip ratio, waist-height ratio, waist-to-thigh ratio, body adiposity index, a body shape index, independent overall adiposity, all these things lead to higher all-cause mortality that is significantly raised in obese individuals. So the larger hip circumference and thigh circumference were associated with a lower risk. So the increased abdominal obesity seems to be very critical in terms of increasing the risk for all-cause mortality. So obesity is something that is really not very good to have, and it is a pro-inflammatory cytokine. And how does intermittent fasting helps in this particular situation? So there are three methods of intermittent fasting. One is called as alternate day fasting, involves alternating between 24-hour fast day when a person eats less than 25% of the usual energy needs, followed by a 24-hour non-fasting day, also called as feast day. So this is one form where you can have complete alternate day fasting, or a modified alternate day fasting, which allows consumption of 25% of calorie needs. So there is another intermittent fasting approach. It's called the periodic fasting or whole day fasting. Periodic fasting involves a consecutive fasting of more than 24 hours, such as 5-2 diet, where there are 1 or 2 fasting days per week, to more extreme version where several days or weeks of fasting. So there are some situations that can be correlated with this. But during the fasting days in the 5-2 diet, the consumption of approximately 500 to 700 calories is allowed, and or about 25% of the daily calorie intake, and may be allowed instead of complete fasting. So this is an approach that could be adopted for obese patients, type 2 diabetic patients with abdominal obesity, but it needs to be followed with great caution in patients with type 1 diabetes. So there is something called time-restricted feeding that involves eating only for a certain number of hours a day. So in this situation, you can skip a meal, and the 16-8 diet shows that there is 16 hours of fasting versus 8 hours of non-fasting. That is the time when you're eating. So these are some of the examples, and this schedule is thought to leverage the circadian rhythm. There is a recent paper a famous neurologist called Paul Zimet from Australia, where he shows how the circadian rhythm is highly important in terms of control of diabetes, and also in terms of your things going wrong with regards to diabetes control that can have. So if you want to adopt the 16-day, 16-18 diet, where you have 16 hours of fasting, it is quite feasible by having your diet taken much earlier during the evening, maybe at 6 o'clock or 7 o'clock, and until next day 6 o'clock, if you don't eat anything, you would have spent 10, 12 hours without eating. And if you skip the breakfast and continue the fasting until say 12 o'clock, you would have got enough number of hours to qualify for this particular pattern of time-restricted feeding. So there are quite a few methods, but all these methods, if the diabetic patient has to adopt, it has to be done in close consultation with the nutritionist as well as the diabetologist who is treating these patients. So if you look at the 5-2 diet in a week of 7 days, 5 days you eat your normal routine calorie consumption, whereas on 2 days a week, you need not have to be alternate days. On 2 other days, you can have restriction in the calories, which is recommended to be 500 calories for women and 600 calories for men. And there are a lot of recipes that are available in the internet where you can have filling diet, where you address the satiety, but the number of calories that filling diet offers is something like 500 or 600 calories. So if you are going to have a diet for 4 times a day, you need to find a way of splitting that into 125 calories per meal 4 times a day, or 150 calories per meal for 4 times a day for men. So this recipes that are available, whether it is vegetarian or non-vegetarian, is going to help you achieve these goals. There may be question whether you want to exercise during this time. Of course, you're allowed to exercise, and you need to have a close watch if you're a diabetic on your diabetes status. So the intermittent fasting regimens hypothesized to impact health outcome. You have complete alternate day fasting, involves alternate fasting days with eating days. Then you have modified fasting regime, time restricted fasting regime, and you also have religious fasting, variety of fasting regimes undertaken for religious or spiritual purpose. So this kind of religious fasting is present across all religions, and some religions have an extended fasting period like Ramadan fasting, which is common in a particular religious group. So there are a lot of religious reasons why people fast, and this fasting has been there for ages in our Indian time. And if you see, the intermittent fasting has been practiced for a very long time. It is just that we never called it as intermittent fasting. But this intermittent fasting has a lot of relevance in terms of the outcome. What kind of outcome we will talk about a little later. So the intermittent fasting has complete alterations in the gut microbiome. As I was referring to Paul Zimmert's work, it also is impacting on the circadian clocks in the body. And the modifiable lifestyle factors like diet, activity, sleep are all important, so that these leverage the intermittent fasting towards inflammation, insulin and lipids, and satiety hormones. And if there are any derangements in any of these, you have obesity, type 2 diabetes, cardiovascular disease, etc. But you can leverage the intermittent fasting in order to try and bring some order, so that the potential mechanisms interlinking intermittent fasting with obesity, cardiovascular diabetes is all addressed in this particular paper in Annals of Reviews Nutrition. So there are a lot of benefits for intermittent fasting. The New England Journal of Medicine review that was published in December 2019 clearly shows that after a century of research on calorie restriction in animals, the overall conclusion was that reduced food intake robustly increases the lifespan. So lower amount of food is definitely beneficial in terms of longevity. And this has been very beautifully shown in the Japanese community called Okinawans, who typically consume a low-calorie diet from energy-poor but nutrient-rich sources, particularly the Okinawan sweet potatoes, other vegetables and legumes. Likewise, number of calorie restriction society who follow the calorie restriction with optimal diet have a low rate for diabetes mellitus. What is important to know in this particular situation is calorie restriction in whatever forms of calorie or protein, fat, carbohydrate restriction may all be common ways of dietary advice that are given to diabetic patients. But what is important is the diet here should be taken as a therapeutic diet, where the diet functions like a medicine, not just in all being used for decreased body weight or decreased calorie intake. So there have been quite a lot of ways by which you can implement the intermittent fasting in order to get the particular outcome which has been proposed in the New England Journal of Medicine paper. So the diet of 3 meals with snacks every day is so ingrained in our culture that a change in this eating pattern will rarely be contemplated by patients and doctors. So it's very important for you to get the patient compliance into this. Second, on switching to intermittent fasting regime, many people will experience hunger, irritability, and reduced ability to concentrate on periods of food restriction. These initial side effects usually disappear within 1 month, and patients should be advised about this fact. Whereas intermittent fasting is not something that you can adopt very quickly, but it should happen over a period of time, which could be 12 weeks or even 16 weeks. The most physicians are not trained to prescribe specific intermittent fasting intervention. Physicians can advise patients to gradually, over a period of several months, reduce the time window during which they will consume the food each day, with the goal of fasting for 16 to 18 hours in a day. So this becomes very important, as you cannot achieve 16 hours of fasting very quickly. It has to happen periodically. After you have successfully achieved 16 hours of fasting, then you can extend it to 18 hours of fasting. So this is something very important to do it in a slow fashion. Physicians can recommend 5-2 intermittent fasting diet with 900 to 1,000 calories consumed one day for the first month, 1 day for a week for the first, then 2 days per week for the second month, followed by 750 calories the subsequent month, and finally by the time you are in the fourth month, you will be eating 500 calories. So this is not something that can happen over a period of weeks, or it has to happen a longer period of time that requires enormous motivation from the patient's concerned. What you would realize is there is something phenomenal that had been observed, that was published in one of the premier journal called Cell Metabolism, where they had looked at the generation of new beta cells in patients who mice that are fed with a low-fat diet. So intermittent fasting improves cardiometabolic health. However, it is unknown whether these effects are solely due to weight loss. So weight loss may be discounted as a reason, and they conducted the first supervised controlled feeding trial to test whether intermittent fasting has benefits independent of weight loss by feeding participants enough food. So weight loss is not the only reason or the important reason for improvement in cardiometabolic health because of the intermittent fasting. So this has been very well documented in this particular paper in Cell Metabolism, where they have also observed formation of new beta cells. And this is something that is important, which you would realize is what has been the age-old practice for people living in India. Clinical management of intermittent fasting in patients with diabetes. So intermittent fasting is becoming very popular. This is something that could be adopted by patients with diabetes, and this is something that could be used as a mainstay of treatment. But here, the diabetic treatment needs to be a teamwork that should involve the nutritionist and the diabetologist. And the nutritionist role here not just becomes calorie restriction or manipulating or adjusting the carbohydrate, fat, and protein, but in terms of identifying the therapeutic diet that is going to be extremely beneficial, like the Okinawan diet. Now, there have been some recent publications that shows that many of the diet, particularly the Mediterranean diet, have an anti-inflammatory effect. Such therapeutic diet is of extreme benefit, where the nutritionist takes over the role of the doctor here in terms of nutritional therapy, and this is becoming very important. This is what I referred to earlier, where fasting mimicking diet promotes changes in the beta cell, with the result beta cell generation happens. So if somebody was asking question, can you reverse diabetes? Yes, you can reverse diabetes. And fasting mimicking diet, which is predominantly what is being used in intermittent fasting, becomes very, very powerful tool. So periodic fasting is healthy and has a positive influence on diabetes. And there have been a lot of literature, even among spiritual leaders, that says that yogis eat one meal a day. The bogies eat much more in a day, and Rogi is the one who is totally indiscriminate in terms of eating. So, as I said, this was a paper that was accepted just last week, published from Chennai by Vijay Vishwanathan's group, where they clearly show yoga, where they had measured the pro-inflammatory cytokines in patients who have been treated with yoga as a therapy over a period of time versus those who did not have yoga, there is a very significant drop in the pro-inflammatory cytokines, which is a phenomenal finding, and it has been observed in other studies published in European journals as well. So this is a very positive thing to show that there is a anti-inflammatory effect for yoga, and there is an anti-inflammatory effect for diet also, where the Mediterranean dietary pattern and inflammation in the older adults clearly show in this meta-analysis of several studies that Mediterranean diet is anti-inflammatory in nature. Now, if you have the components of the Mediterranean diet added to a yoga, you have a clear opportunity to decrease inflammation, thereby decreasing the diabetes intensity and insulin resistance and abdominal obesity and weight reduction, in addition to anti-inflammatory activity, makes it extremely interesting from the intermittent fasting point of view. So with this, I thank you very much for your attention. There are ways by which you can contact me for any additional information. If you are fond of or in Facebook, you can go and click on Thoughts on Diabetes, where you can find a lot of recent publications in diabetes that are being listed there in this particular page so that you can update yourself. With this, I thank you very much for your attention, and I'm thanking Dr. Alok Kanungo for the opportunity. Thank you. Bye.